My name is Robert Boutin, and we will be talking about some hot topics this year. The biggest and baddest development in radiology. Does anybody know what this might be? AI. You know, Benjamin Franklin famously said there are no constants in life other than death and taxes, but I think to that we have to add AI, artificial intelligence. And one of the things that really supercharged this whole area recently was ChatGPT, originally launched last November and then upregulated a few months ago with ChatGPT 4's release. ChatGPT, of course, is a name that comes from it being a chatbot with a certain type of AI model, a generative pre-trained transformer, GPT. And the initial version was trained on this vast amount of unlabeled data, 400 billion pieces of text, more than $100 million of R&D. People don't really know how much. And now with the new version, it's even more. And it's interesting that whereas robots a decade ago or two were threatening blue-collar workers, in factories now, knowledge workers are feeling threatened. Even surgeons felt like they were sort of immune to all of this, but now there are articles coming out that robots are going to be controlled by ChatGPT and other AI instruments like this. A lot of articles coming out even this year saying that this is a double-edged sword, you know, sort of like fire or atomic energy. Could be good, could be bad. There are others say it's an intellectual revolution as big as the printing press or the Enlightenment, so says Eric Schmidt, the former Google CEO. And this, I think, is the most interesting quote, last one I'll mention, is in the worst case scenario, AI could kill us all. So says Sam Altman, the OpenAI CEO who is in charge of this. It turns out that there are a lot of different large language models that are affecting radiology and beyond. It's going to help us, I think, with report generation, but also it's going to use our reports for analysis, both by the Big Brother, the institutions and private payers and things, but also for translating our reports to patients. And it brings up this new term of integrative diagnostics.
All right, and I'm Bill Morrison, and we'll talk about sports injuries in high-performance athletes and return to play. This will have a little overlap with the last talk, but I think it's good to reinforce. I apologize for all you Dolphins fans and other fans, but we're going to have a lot of Eagles images here. A lot of the cases, not all of them, are professional athletes. I won't name them, but you know, a lot of them are recognizable people. But in any case, one of the more common injuries that we see are muscle and tendon injuries, especially the musculotendinous junction. But we see them as overuse, acute injuries, and acute on top of chronic injuries in these players. Direct injuries, we get muscle belly injuries, especially contact sports. But the most common thing that we see are indirect injuries, what they call eccentric contraction injuries. And that's related to acceleration, deceleration sports. You know, like the wide receiver that stops and turns quickly. And they have these musculotendinous injuries at the junction. And injuries tend to occur at the junctions of mechanical points, transition points of mechanics in these constructs. But you have definitely a lot of players that get struck. So we have contact injuries, and we'll often see those in the thigh in people in contact sports. So here's a rectus femoris tear, and that can be related to acceleration, deceleration, but oftentimes these are direct blows. This is a partial tear involving the rectus femoris. And the important thing is a lot of times the player doesn't realize they get hit, but later on they feel a lump there and pain. And a lot of times the question is whether they have a mass, but obviously it's usually a tear. This is a professional football player with a quadriceps hematoma, and the way we look for hematomas is on T1 weighted images, and you look for the bright signal on T1. And bright signal on T1, it's blood, fat, or gadolinium. If you didn't give contrast, it's either blood or fat, and if it's a focus in the muscle, it's going to be a hematoma. So the question is what to do with this. If you let it heal, sometimes it heals with fibrosis and limited range of motion, depending on the location. If you drain it, a lot of times it can reaccumulate. So it's a little controversial how to treat these players right now. Overuse has been called delayed onset muscle soreness. And we'll see this in not usually this type of person, but usually, the weekend warrior who overdoes things, because the high performance athletes are generally well trained and conditioned, so they tend not to get this condition. What they do tend to get, especially adolescent athletes, as the muscles grow and the fascia can't accommodate as well, is we get some ischemic injury or chronic exercise-induced compartment syndromes in the lower.
We're going to wrap up now with the knee and some this is kind of a little bit higher level musculoskeletal imaging, but even though it's a little bit more complicated than some of the things that we covered, I think what you'll see is that this is something that you will have to interpret, understand, and communicate with your referrers because of these surgeries are happening so commonly, so frequently. So, I think we all know this in the knee. We have two cruciate ligaments. We have your anterior cruciate ligament and your posterior cruciate ligament, both very important. And then obviously in terms of functionality, but they're also important in terms of pathology because they both tear, which can be a big problem for patients. Now, ACL tears tear much more frequently than the PCL tears, but again, both very important. Let's look at the ACLs first. If you just compare a recent period of time, there's a 22% increase in the number of patients getting ACL reconstructions, right? So very big deal. It's the smaller group. It's the 13 to 17 age group where it's the highest increase, which really speaks to more increased activity for these kids, what they're doing, which is a separate topic, a different discussion, is are we doing too much with our kids? But there's also increases in patients who are getting ACL reconstructions, plus meniscal repairs, meniscectomies. Interesting enough, no difference in gender rates when you look at the literature. So what does this mean for the radiologists here in the room and the clinicians here who see these patients? Number one, more surgeries means more likelihood for patients getting re-injured, surgical failure, surgical complications, right? So if anything goes wrong, there's suspicion for something going wrong in the knee after ACL reconstruction or even PCL reconstruction, the first thing they're going to do is getting an MRI. Right, so that post-operative MRI. So given the numbers, just looking at the numbers, looking at the data, the fact that so many people are getting the surgeries, more people are going to get these potential complications, more people are going to get MRIs. So whether you're someone who just reads MSK or is a general radiologist, you're going to be seeing this on your work list. So objectives here are going to go over some of the basics of cruciate surgery. We're not going to dive in too much because we're not all orthopedic surgeons here, but I think understanding what happens before you see the imaging will help you understand I think will help you better interpret what you do see on the imaging. We're going to go over the normal post-op appearance of these ligaments, very important, right? Because if you don't know what normal is, then it's going to make diagnosing abnormal harder. And then we're going to go over the most common complications, things that you'll see in practice. So hopefully, if you see him here, then when you see him in practice, it'll be so much easier. You describe him correctly. And again, a common theme in our lectures today is you'll give the information that the patient and the clinician needs to make the appropriate clinical decision. So let's talk about our ACLs.